Good morning to everyone. I am Dr. Tharani from Stivala Dental College and Hospital, Department of Oral and Maxillofacial Surgery. Today I am going to talk on orofacial cleft. Orofacial cleft are congenital deformity which manifest at birth. Any disturbance during the embryological formation may lead to orofacial cleft. Cleft meaning crack, fissure, split or a gap. Cleft lip and cleft palate may cause a deformity like dental problem, skeletal problem, nasal problem, feeding problem, ear problem, speech problem and associated anomalies like congenital heart defect and mental retardation. Various types of cleft lip and cleft palate over India are high prone for cleft lip and cleft palate. The Hippocrates in 400 BC and Gallian in 150 AD were found that first cleft lip and not a cleft palate. And the cleft lip was first found by Franco in 1556. The repair of cleft lip was as early as 255 and 206 BC in China. The first successful closure of soft palate defect was reported in 1768 by Lee Mortain, a French dentist. The Kingsley in 1880, oral deformities of a branch of mechanical surgery. Calvin cases in 1921, a practice of treating a technique and principle of dental orthopedics and prosthetic correction of cleft palate. The Cooper in 1930s introduced the integrated clean concept of formation of Lancer cleft palate cleaning. The two interrogations started in the meeting minded over the individual who first examined the patient together and agree the program together. The exact etiology of cleft lip and cleft palate was unknown. The instead of cleft is though the multifactorial etiology, the sum may be reported as syndromic and non-syndromic factor involved in cleft lip and cleft palate. Some of the syndrome involving the cleft lip and cleft palate are Morphin syndrome, Apert syndrome, Down syndrome, Dye-Jogren syndrome, Edwards syndrome, Pyrie-Robbins syndrome. Many workers are viewed in the cleft occur during the number of cases. No single etiology can be pinpointed. Heredity of 1 in 3 children with the cleft has found. The environmental factor involved in cleft lip and cleft palate are womb environment, external environment, nutritional environment and drug related. The drug related are anti-abortion drug, anti-emetic drug, anti-epileptic drugs. And some of the teratogenics are rubella virus, cortisone, metacorpazone, methotrexate and Valium. The infection like rubella, staphylococcus and toxidosum are involved in the cleft lip and cleft palate. The multifactorial etiology. Recent study shows the etiology of cleft lip and cleft palate cannot be attributed solely either by genetic or immunological factor. It seems to be involved in more than the one factor. According to the certain study, up to 30% of cleft lip and cleft palate are together and 50% of purely cleft palate are related to the syndrome. Predisposing factors are high maternal age, diabetes, toxemia, blood supply and folic acid deficiency and racial and radiation. The embryology of cleft lip and cleft palate are by the development of facial structures starting at the end of 4th week. The 5 facial prominence around the stromatodium are unpaired frontonasal process, paired maxillary prominence and paired mandibular prominence. The frontonasal process gives us a bridge of the nose, medial nasal process gives us the tip of the nose and the philtrum of upper lip, and the lateral nasal process gives us the aloe of the nose. The primary palate, maxilla and medial nasal process merges. Formation of intermaxillary segmented by the merging of medial nasal prominence. The formation of cleft by means of failure of fusion of maxillary and medial nasal process, it led to the anterior to the incisive foramen cleft. The failure of fusion of palatal shelf may lead to posterior to the incisive foramen cleft and the cleft lip by the failure of proliferation of mesodermal midline. The anatomy of cleft lip and cleft palate are by the structure like muscle, bones, blood supply and nerve supplies. The lip is highly involved by the orbicularis oculi muscle improper fusion. The hard palate is by bone, maxilla of palatine process and palatine bone of horizontal lamina. The blood supply of hard palate are greater palatine artery and nerve supply of anterior palatine nerve. The soft palate are fibrous muscular sheath attached to the shelf to the posterior portion of hard palate, denser levator and contact to the passivant ridges. The muscles are tensor vallipalatin, levator vallipalatin and the ovula, palatoglossus and palatopharyngeus. The normal lip anatomy are nasal columnar, philtrum columnar, white roll of the submucous vermiform border, tubercles, cupid's bow, wet dry border. The muscles are orbicularis oculi, uses a muscle across the midline and create the opposing filtering column. The function of the splinter and speech. The beta labii superioris gives us a insertion into the dermis at the verminal border and to the lower edge of the filtering column. Thus the elevation of the upper lip. Nasae and depressor septi nasae muscles is a fibrous run along the alveolar bone into the medial distal foot. The normal measurement are the vertical length of the upper lip in newborn of about 10 mm. At the age of 3 months, it raises to 30 mm in adult of about 70 mm. The distance between the peak of a cupid bow approximately 3 mm at the 3 months. The arterial blood supply are the labial artery bilaterally, the sensory innervation of trigeminal nerve, cranial nerve of fifth, and the maxillary division of trigeminal nerve. The motor innervation are the maxillofacial nerve, the seventh cranial nerve, and zygomatic and buccal branches. The alteration of the orbicularis oculi, levator labii, and nasal result in disruption and discontinuity, orientation, and quality of the muscles. The vertical lip length is decreases. The cupid's bow and the lip is rotated on the both sides laterally, the cleft side as well as the medial side. Disruption of the cupid's bow, the alveolar and nostril floor of the opening the complete lip. The premaxillary is rotated and protruded. The associated cleft lip are nasal abnormalities by hypoplasia, flattening of the alar dome of the affected side, the lack of upper lip cartilage overlaying the lower lateral cartilage, subluxation of the lower lateral cartilage to the alar base displaced posteriorly, hypoplastic bony foundation maxilla, flattening of the nasal bone, shortening of a columnar, especially in the bilateral cases. Various classification given by the various authors. Generally, the cleft can be of unilateral or bilateral, incomplete or complete, may be involved in the lip, nose, primary palate or a secondary palate. Blixus gives a cleft classification by syndromic, familial and non-familial classification. Davidson and Ritchie classified in 1922 and Victor View classified in 1931. Carnaps and Stacks gives us a classification in 1958. American Cleft Palate Craniofacial Association classified in 1962. Carnaps and Stacks Stips Y classification given in 1971. Spina classification in 1973. Carnaps and Stacks Splitting Y modified by the Elsters and Milliards in 1976. Stewart's and Spezia's syndromic classification. Lassell classification by O'Krines in 1887. Lawson yardsticks classification and Goslin's index classification. The radiographic finding are generally by the ultrasound technique. Non-invasive diagnostic tool confirms the fetal viability, determine the gestation ages, establish the number of fetus and their growth, check the placental location, examine the fetal anatomy and detect the malfunction. The trans-abdominal US are non-reliably by the gestatory ages at 15 weeks, done at the 2 or more weeks of gestation. Transvaginal USG early visualized in 12 weeks, better imaging resolution, greater specificity and sensitivity. Packwood and Guns in 1997 started the coronal plane, assessing the continuity of axial view. Bilateral cleft has sagittal view, isolated cleft axial view. Advantages of prenatal cleft diagnosis is by psychological preparation of the parents having a realistic expectation, parents' education for the cleft management, preparation of the neonatal care feeding, opportunity to investigate other abnormalities, possibilities of the fetal growth. Disadvantage of prenatal cleft diagnosis: emotional disturbance, high maternal anxiety and dysfunction, terminal of pregnancy. Theories of cleft lip and cleft palate are: theories of failure of mesoderm migration, Fleischmann's geologist professor from German in 1910, and theory of disc Hus in 1931, fusion theory. Mesoderm reinforcement theory given by Victor Vio in 1935, supported by the Stock in 1954 as a mesodermal migration theory. Finally, none of the theories are universally accepted. Multidisciplinary management of cleft lip and cleft palate are ENT, audiologist, dentist, surgeon, nursing, genetics, social workers, ophthalmologist, psychologist, pediatrician, and speech therapist. The timing cycle of conservative management of surgery orthodontic are given in 1980s. At birth, the external elastic need to be placed to over the protruding premaxilla. No obturator are necessary. In 3 to 4 weeks, lip adhesion is required. In 6 months, miliar forks flaps is required. In 18 to 30 months, the one Lahermans is required. In 4 to 5 years, the correction of buccal prospect is required. In 5 to 7 years, fixed palatal retention are required. In 7 years, the orthodontic and the surgery are parallelly undergone the alignment of teeth before the surgical alveolar bone grafting and the secondary alveolar bone grafting with the cranial or iliac bone. In 9 to 13 years, the full banded treatment with or without maxillary protrusions are required. Nasal tip and lip revision surgery is required. In 13 to 17 years, full orthodontic evaluation needed to pre-surgical orthodontics, maxillomandibular surgery, nasal lip revision is required. In 17 to 18 years, the post-surgical orthodontic follow-up by prosthesis, nasal lip revision is required. Philippinia Centers of Research in Child Growth, Wiltian Growth uses a time period by basis of 8 phases. The first stage is prenatal phase. The complete history of gestational and maternal change is counseling for the patient, parents, genetic and the social workers. The second stage at birth, the third stage at the 1 year, and fourth stage is at 1 to 2 years, and fifth stage is at 2 to 6 years, and sixth stage at 7th stage at 12 to 18 years, and 8th stage at 12 years onwards. The Norway cleft lip and cleft palate management in Oslo has given us no pre-operative orthopedics, closure of cleft in infancy miliar procedure, the closure of remaining isolated cleft by one Laherman in 18 months, and second operation at 18 to 30 years of age. Fisherman gives us that based on the development of dentition, the pre-dental treatment at 1 to 18 months of age, deciduous dentition in 3 to 6 years, and early mixed dentition at 7 to 9 years, and later and mixed early dentition at 9 years onwards. Profit uses the infancy before the initial surgical repair of the lip. During the later primary and early dentition, later the mixed to the early dentition, and later neonatal stage, dentition stage, and deciduous dentition stage, mixed dentition stage, and permanent dentition. Nasoalveolar molding. In cleft palate, nasoalveolar molding is highly required. Hoffman in 1678, extraoral device is detected to produce a premaxilla. McRellan in 1950, pre-surgical orthopedics is required. Hertz in premaxillary is normally paced by 10-year phase growth. Downward and forward into the balance with premaxilla. Grayson's in 1983, first technique of correcting the alveolar lip and nose and cleft infant. Metu in 1988, research for the cartilage molding. High maternal level of estrogen at the time of birth correlated with the increase of high hyaluronic acid, which inhibits the linking of cartilage intercellular matrix. Matusu uses a stunt silicon tube shaped nostril, and Grayson in 1999 adopted the nasal stunt to extend the anterior flange of intraoral molding plate. This is a new technique was named nasoalveolar molding. The objective of nasoalveolar molding is to reduce the severity of initial cleft deformity, columnar, the non-surgical lengthening in a bilateral cleft, and the uprighting in a unilateral cleft. Reduction with the width of the alveolar cleft segment until the passive contact with the gingival tissue is achieved. Procedure done for nasoalveolar molding is a heavy bodily impression. Material is used to take a initial impression as soon as birth as possible. Grayson and Muller in 1999 as infant upside down position, keep the tongue forward and permit the fluid to draw in the oral cavity when the impression is taken. Young in 2002 took the impression using a pre-trimmed custom-made pediatric tray with the baby being held correction position by one of the pair. Patson in 203 and Mitchells in 2010 obtaining the impression when the infants are awake, provoke position with the dental chair. Child is held to tap to the parents with no anesthesia. Dubé in 2011 made the impression of the cleft region upper arch using an ice cream stick and impression molding. Plates are clear, self-cure. 2 to 3 mm of thickness. The retention arm of 40 degrees to get approximate activated and avoid the dislodging of enamel plating. The nasal stamp is added to the intraoral molding plate and the alveolar gap is reduced to 5 mm or less. Center of 0.038 gauge rolled stainless steel wire is intranasal positioning on the hot upper lip. Elastics are used in 0.25 inches to avoid a stretchy 2 times of diameter activated the post and above the 2 roots. Stages of treatment. Passive maxillary obturator is an intraoral prosthetic device which fills the palatal cleft to provide the false roofing against the child sucking. Reduces the feeding difficulty like insufficient sucking, choking, asphyxia, or intake. Pre-surgical orthopedic facilitates the creation of good functional palate, normalize the tongue position, helps the speech development, improves the symmetrical of nose and cleft maxilla, psychological boosting of a patient and parent to continue the position. Management of cleft lip by tensor randula izzoplasty, miliar rotation advancement repair, Rosan Thomas straight line repair, Megcomb technique. Cleft lip repair, a goal to improve the facial aesthetic by restoring the nasal and lip contour at the time of 3 to 6 months. Miliar rule of 10, term coined by Versing and Musgrave in 1968. 10 weeks of age, 10 pounds of weight, and 10 grams per deciliter of hemoglobin. The techniques are tensor randula izzoplasty, miliar rotation advancement, and Rosan Thomas technique. Surgery for the cleft palate are Van Lagenbach, VY palatoplasty by Leo, Furlow technique, Ward Frenzen pushback technique. Bone graft for alveolar cleft defect by means of primary bone graft and secondary bone graft. Primary bone graft was done in first 2 years of life and early 2 to 5 years of life and later of 11 to 14 years of life. Objective of surgical grafting is to stabilize the grafting, improve the oral hygiene, nasal secretion, preventing the drainage of a unit of maxilla to the better withstand of occlusal force, bony bases of the teeth eruption, improves the nasal symmetry, provides the feeling of normalize and improves the social concepts. Velopharyngeal impairment. Velopharyngeal impairment is an insufficient contact between the velum and the posterior and lateral pharyngeal wall. Velopharyngeal insufficiency deficiency. Velopharyngeal incompetent neuromuscular. Surgical lip closure. The primary closure of lip is under the age of 3 months or 10 weeks. When the child is fit to undergo general anesthesia, the miliar suggests the rule of 10, approximately 10 weeks of age, 10 pounds, the blood hemoglobin of 10 grams, Benson triangular flap procedure and miliar rotation procedure and with the other techniques of VO repair, where A is the rotational flap, B the advancement flap and C the columnar flap. A and C are planned to the medial side of the cleft. After the full thickness of lip is cut along the marking is filled by the B. Prior to the lateral side of the method, minimal tissue is discarded and the resulting modification during the surgery. Milliard's technique is as cut as you go technique. Preserve the cupid's bow and philtrum dimple. The tension of the closure of the alar base reduces the flare and promotes the better molding of the underlying alveolar process. Surgical management of cleft palate is to production of competent velopharyngeal splinter. Two most common repair are Van Lagerman and VY. The main difference of VY repair is around the elongation of a palate while the Langenbank does not. Batch 2 flaps of palatoplasty. Furlow double opposing izzoplasty. Using a too large full thickness layering of dissection and draw the midline for the closure is batch 2 flap palatoplasty. Furlow is a common technique attempted to lengthening the palate by taking the advantages of izzoplasty technique on the both nasal mucosa and oral mucosa. Bone grafting is only a bilateral alveolar cleft is fixed to the mobilized of premaxilla extended to the achieving a continuous alveolar cleft in an alveolar process. Soft palate correction is by intra-alveolar veloplasty, Weidemeyer VY plasty, Furlow and TPE, Furlow veloplasty with the tensor procedure, Parker Furlow plasty, Intra-alveolar veloplasty type 3, the primary cleft repair of old children and adults. Hot palate surgery is by a caudal-based warmer flap, laryngogluteus, Campbell, Georg and Stenson-Strohm styler. Some correction surgery of orofacial cleft are veloplasty, rhinoplasty, keloplasty, and pharyngoplasty. Type of repair are straight line repair. Histologically, the first cleft lip repair receives and refreshing the edge of the cleft and suturing them together. This has been largely replaced by the various izzoplasty-based techniques. Rosen-Thomas repair, the modified straight line repair that can be used in a minor cleft with the lip lengthening nearly equal or both sides of the cleft. Example, formicosity. Fusiform is excision with the straight line closure. Quadrangle flap is proposed by Lee, Messier, and H. Grown. Cupid's bow is derived from the lateral lip, 90 degrees of izzoplasty. Violating the cupid's bow and philtrum dimple has a tendency to procedure of long lip. Triangular flap is a repair was initially described in 1952 by Tenson. In 1959, Randall described the mathematical approaches to the triangular flap that was on the basis of physics measure. This repair technique is conceptually similar to the rotational advancement repair. The primary difference is that the rotation backward cut in the non-cleft segment is performed more inferiorly, close to the vermilion border. Similarly, the advancement segment on the cleft side is designed to occur inferiorly near the vermilion cutaneous border. The marking of unilateral cleft lip repair with the triangular flap technique is marking reference indicated the following 11 points are columnar base non-cleft side, columnar base cleft side, alar base non-cleft side, alar base cleft side, light scroll mark non-cleft side, light scroll mark cleft side. This also became the medial base of the equivalent triangular flap. Peak of the cupid's bow non-cleft side, low point of cupid's bow, apex of the equivalent triangle flap, lateral base of the equivalent triangular flap, mark of the length of the back cut non-cleft side. There are three main advantages of triangular repair technique. The first is readily used to close the wide cleft without having performing a lip adhesion and pre-surgical tissue manipulation. The second, the operation is done on the strictly geometrical method of mathematical principle and measurement, leaving not much room for error in judgment when compared to the cut as you go technique. Therefore, many experts consider the triangular technique flap to be well suited for the less experienced surgeon. The third possible advantages of this technique is zigzag scar prevention, scar contracture of lip, shortening lid to the vermilion notch that can be sometimes observed in the rotational advancement technique. The main disadvantage of triangular flap repair is that philtrum of the cleft side violating by the triangular flap. Some author believe this leaves some noticeable scar. Another potential disadvantage in the difficult modification repair is performed secondary revision at the later stage due to the zigzag scar. Scope repair consists of two izzoplasties violating the cupid's bow and philtrum dimple. Rotational advancement is a repair of the unilateral cleft lip deformity as described earlier. The most common used method in repair at the present in USA. The main advantage of this technique is flexibility and applicable. The rotation advancement technique is relatively cut as you go. The strategy that allows to continue modification during the designation of repair. The strict geometrical principle is followed. The primary disadvantage of rotation advancement technique is that experience the artistry required to achieve the optimal result. The shortening of a lip on the cleft side with the resultant vermilion border notch and whistling disorder. The unilateral cleft marking of rotation advancement technique are low point of the cupid bow, the peak of the cupid bow lateral to the non-cleft side, peak of the cupid bow medial and non-cleft side, alar base of non-cleft side, columnar base of the non-cleft side, back cut of non-cleft side, oral commissure non-cleft side, oral commissure of left side, and light stole and medial tip of the advancement flap, middle point of alar base, lateral course of alar base, and lateral of the alar base to the extensor anatomy. Bilateral cleft repair. The premaxillary segment is often greater problem in a unilateral cleft, consists of tapering, lip adhesion, and pre-surgical osmosis. The most common techniques are dissection of prolabia to maintain the central skin flap resembles the filtrum, deep epithelial remainder of a prolabia, creating the labial sulcus not on the final regulant border. Columnar lengthening may be performed in the time of lip repair of the secondary procedure. Post-surgical complications of cleft lip and cleft palate are based on unilateral and bilateral. In cleft lip surgery, unilaterally it causes a dehiscence, infection, thin white roll tension, bilaterally by dehiscence, thin white roll. In cleft palate repair, fistula, velopharyngeal incompetency, and Stenson side port. Alveolar bone grafting, infection of a donor site, hematoma, failure of graft, dehiscence, and palatal prosthetic. In mid-phase advancement, the leafwood osteotomy, malocclusion, infection, necrosis, rhinoplasty of allostomes. Role of ENT specialists and speech pathologists in the speech therapies are ear problems. In the cleft patient, due to the abnormal function of Custom tube, there is an increased risk of otitis media. The parents are counseled to possible hearing loss. ENT specialist, audiologist, and the speech specialist work together to note the ear problem and progress the speech. The speech therapy is started at the 6 months of age if needed to continue till the adult. The surgical treatment of maxillary growth defect. Roughly 1 in 4 patients with cleft lip and cleft palate develop a defect in growth of upper mandibular and midface. The resulting severe malocclusion can be a major determination impact of mandibular function and facial appearance, which can be psychologically difficult for the teenagers. A growth defect of maxilla can be corrected through the orthodontic and orthognathic surgeries. The mandibular osteotomy is sometimes required to correct the facial structure. The nasal deformity is typically a cleft palate may be of leafwood 1 osteotomy. Lip and nose revision surgery, nasal surgery, rhinoplasty and lip surgery of revision cleidoplasty can be necessary to improve the appearance and function of nose. Lip has been deteriorated to the growth after the initial surgery. The nose may be appear flattened or there may be a asymmetry of the nose. There may be of nasal obstruction due to the small nostril or deviation of septum. Surgical to the revision of appearance of lip and nose may take the place in child start schools during the teenagers years, depending on the recommendation of plastic surgery. Pharyngoplasty, the child with the repair of cleft palate may have a resultant condition of revision of velopharyngeal incompetency. This occurs because of the repair of soft palate too short at a smooth. This helps in direction to the type of intervention which is more prominent. This condition is diagnosed primarily by the training of ear speech specialist. Post-operative care, the arm restriction of 3 weeks to be prevent disruption of repair. Breastfeeding is controversial based on the surgeon preference. Leave steri-strip to place the incision of reinforcement. Follow up for 1 week. Suture removal, non-observable skin suture. Complication, inadequate, inappropriate ororbicularis oris muscle is failure in reconstruction of potential oral sphincters may resulting in muscle bulging in readily appear to the skin, repairing of lip on dynamic motion. Inadequate alignment of vermilan cutaneous junction, leaving a small step of deformity reliably noticeable even in the untrained eye. Vertical scar contracture is inadequate rotation causes a shortening of a lip segment led to notch of vermilan border and crisping. Scar contracture is to be nasal, narrow nostril still the vermilan, vestibular stenosis. Wound healing complications such as dehiscence and scarring. Recent advancements are fetal surgery, non-life-threatening defect, syndromic, open fetal surgery, fetal Cleft lip and cleft palate is a multidisciplinary approaches for the management of patient-centered by means of ENT, speech therapist, psychiatrist, and other specialty of oral maxillofacial surgeons were playing an important role in the reconstruction of cleft lip and cleft palate. Thank you.